Welcome to the GU Oncology Now community. I'm so thrilled to be here. My name is Katy Beckermann. I'm a GU medical oncologist at Tennessee Oncology, and I would love to have Libby introduce herself, joining the call today to talk about symptom management, palliative care, talking to patients. Thanks so much for joining us, Libby.
Yeah, my name's Libby Wulff-Burchfield. I am a genitourinary medical oncologist and a palliative care physician at the University of Kansas.
Libby would love to start off with a question about, when you're sitting down with a patient, and whether it's maybe that first consult or maybe you're thinking about, switching treatments. I
Mhm.
know you have done a lot of research in symptom management and, kind of healthcare and patient-reported outcomes. How do you think about talking to the patient and saying, you know, what are your goals?
Mhm.
Here's the symptoms that might come from your disease or from treatment, and how do you make that kind of joint decision making?
Sure. Well, thanks for having me. I'm so glad and proud for this to be highlighted because I think at the heart of what we all do is the patient experience. And so I'm really glad to be able to parse that out a little bit. So for me, when I'm talking to patients about changing treatments or in for engaging in shared decision making, we're always trying to weave in their perspective on what their goals are for their life, what they think is important in their life, and the ways that their cancer and or the treatment will facilitate those goals or potentially put those goals at risk. And so what I generally do is when I'm talking to patients, I'm pretty honest about what I think their symptom experience may be with treatment. That's so hard when immunotherapy is being offered to them because we are so poorly equipped to predict the individual patient experience on immunotherapy. I have some patients who have no symptoms and some patients who have life-threatening side effects. But with things that are a little bit more predictable, I often phrase the discussion around, again, hopefully I've gotten to know them. Or if I'm just getting to know them, I often will ask, like, how do you spend your time? Or if you're feeling better, how would you spend your time? What are the things that feel intrinsically you? What makes Bob Bob, et cetera, and trying to understand what are the barriers now. So if that, I have patients who I live in the Midwest. My patients love caring for their yards. I can't even tell you how many patients just love doing yard work and gardening. And while that would seem like a chore to some of us, that is something that they really value and is an immense source of joy and pride for them. So trying to understand, okay, well, Bob, are you mowing the lawn now? Are you able to stoop down to do the gardening? I mean, all of those things to understand where they are, and then trying to understand how much either the cancer is actively putting that at risk or would if they choose not to do treatment, let's say, or what the treatment may do in terms of posing risk to those hobbies. So if someone has a, a 1.5 acre yard and they want to mow that on foot, if they are going to be receiving a treatment that has a risk of palmar plantar erythrodysesthesia, then that may put that at risk because that's a lot of friction on their feet. I also try to phrase it as making the choice to knowingly trade cancer symptoms, which can be really hard to control, for treatment symptoms, which we often can control quite well, with the exception of fatigue, but that goes a lot, that's kind of there either way. So that's a lot of how I try to frame it is so I realize that no one is making a choice for wanting to be on treatment for the sake of it. They're choosing life. They're accepting treatment as the mechanism whereby they can pursue that goal, but then knowingly making the choice to trade out those cancer symptoms like pain, like hematuria, depending on what they have going on, like cough, it could be different things, for symptoms that will need their own management, but are often more manageable, potentially diarrhea, needing thyroid medication, putting creams on their hands and feet, those sorts of things. So that's the framework I found to be most successful.
Those are great, and I think those are some great bites for us to take and to use. I wonder in that context when you're talking, and because you are a subspecialized and treat patients with GU
Mhm.
malignancies, do you find that there's certain symptom burden, certain disease characteristics that come from GU malignancies compared to kind of other just broadly, solid tumors that you
Mhm.
tend to focus on?
Well, I mean, the cancer related symptoms and treatment related symptoms are going to be unique for any solid tumor, more or less. So, my patients who are dealing with prostate cancer, the, symptom complex that goes along with ADT is really unique to that population. Even male patients with breast cancer don't have the same symptom complex with their hormone manipulation that our patients with prostate cancer on androgen deprivation therapy and other androgen related blockade agents cause. That's unique, which is that kind of hot flash, night sweat, loss of muscle bulk, erectile dysfunction, loss of libido. That whole symptom complex is really unique. But also unique on the cancer side can be urinary obstructive symptoms, can be hematuria sometimes, and certainly bone pain can be an issue. For our patients with bladder cancer, I think because the metastatic pattern is a little bit less sort of predictable than with some of these other cancers, that can be a little bit all over the map. But again, if they have their bladder intact, hematuria can be an issue. And I'll be honest, I think there that is a really tricky symptom to manage. That also can impact patients with prostate cancer who may have radiation cystitis, for example. But boy, that's hard. They end up getting in the ER. They have a lot of management with catheters. Managing their ostomy is unique. And then with treatment, I would say nowadays with some of the agents that we use for management of urothelial carcinoma, neuropathy, peripheral sensory, and to some degree motor neuropathy is a big deal now. And then for renal cell carcinoma, patients can have hematuria because more patients are keeping their kidneys now than when was in training. And so we can see hematuria, some and flank pain, some patients, we have a variety of symptom or of metastatic patterns. And so I do have patients, who have bone metastases, and bone pain can be an issue there. But again, the symptom complex with the treatments is very unique. And I would also say another, factor that's really important for urothelial and for urothelial and renal cell carcinoma, excuse me, is the unpredictability of immune checkpoint inhibition. That's hard, and that's its own sort of emotional mental burden for patients, in addition to the symptom burden that could be rash, achy joints, all those sorts of things. And with renal cell carcinoma, certainly this unusual symptom pattern, at least compared to what patients expect when they're going on to treatment of, PPE, diarrhea, so to some degree rash, in addition to things like, asthenia and such. It's very different. I feel like that's some of that variety is baked into GU oncology.
Yeah, no, I think that's very helpful. And I appreciate that you also highlighted, our treatment. So there's, disease specific symptoms, and each of our treatments certainly have their own side effect profile.